Good day. Thank you for all attending. I'm Captain Craig M. Johnson, ESU Commanding Officer, and this briefing and adjustment inquiry is based upon Proposal Case 2017-4-23-10. It's in reference to an event that occurred back in April of 2017, this year. And this is a briefing for all those of the Bureau of Fire Prevention in going through certain aspects and proposals of what we currently do based on what we could do to perform better. In this particular case, it brought many different instances to light of what actually happened. As I said before, I'm Craig M. Johnson, EMTP, BHS, Commanding Officer of ESU Division, and our response today is the meeting that we are having in regards to what happened on those events of 23rd of April 2017. The accident occurred approximately 10 a.m. A young man at age 28 lost his life in a motor vehicle accident, and this actually brought forward many different issues that we need to correct within the department to where we can prevent accidents from happening again due to situations that were brought up that happened on scene. The department actually wasn't involved into the accident until the response. It was what happening while responding became the clear path. The department was cleared of all liability resulting in the unfortunate death of the individual. However, the agreement is there could have been more we could have done had we had the tools and the processes that some departments have in place that we do not. And this inquiries go forward with that to bring these to mind and into the open and come to a better understanding of how we do things and why we do things in the field to make it much easier for everyone else. The first part is what went wrong to cause this inquiry. First part is that there was prolonged on-scene time due to large patient in the vehicle and the sheer lack of manpower. There was unable to get intravenous access to the patient for various different reasons, and there was an inability to endotracheal intubate the patient to provide airway access due to a clenched jaw issue that is common with traumatic patients that are involved in a traumatic event where there's a significant MOI or mechanism of injury. There was also another problem where there was no portable HRST tool available because the only people responding were just a rescue, a light rescue, which is only designed for emergency medical responses, or in simple terms, ambulances, versus a heavy rescue, which is what we would commonly call a tool truck. And within the aftermath of this, some other issues came to light. Information was given to the press without authorization from an unassociated unit that did not respond to the actual incident. The information was inaccurate and was a violation of department policy and federally mandated Health Information Privacy Protection Act laws. The individual at fault was given a verbal warning. Unfortunately, the individual was only given a verbal warning because there was no sound policy in place at that time. At this time, this has looked like something we want to correct moving forward from this date. To start things off, there is a couple recommendations to the Bureau of Fire Prevention that we want to actually influence changes. First, there is a need to reorganization of heavy rescue and equipment resources around the department, different areas. This is actually being implemented by the Deputy Chief of Operations, Chief Williams, and is ongoing. Unfortunately, I have no say over this policy. This actually comes from him. However, he is on board with this change and is actually working on his end to fix this. This can be done easily through his office. It does not have to go to the Bureau. However, for me, it does. I have to bring this to you because there's other changes. In this case, first off, is new equipment on light rescues, ambulances, that I want to bring into the fold, and also new house policies and disciplinary actions for violations of HIPAA policies. To start things off, the focus change for light rescue is we want to bring in some new devices into light rescues. In this case, one of the problems that we had on scene was the lack of airway access, that we couldn't get to the patient in time. He had a clenched jaw, therefore we were bagging him through his teeth, essentially, for those of you who are not involved in emergency services. We want to bring in a few different adjuncts that can actually help paramedics do their job much more effectively and efficiently, as well as quickly. Speed is 90% of our job. Speed has to be the most priority. The sooner you get the patient care established, the sooner you get them to the hospital, the greater the chances of their survival. The first part is the focus changes for light rescue is the rapid intubation tactics availability for cardiac arrest without clenched jaw, where the jaw is not closed shut. It's quick airway access in need of prevention of long scene delay. The proposed device is called the LMA, or laryngeal mask airway. It's a simple adjunct that all EMTPs are trained to use. We just do not carry them at this time for whatever reason that is. It is not on our policy and procedure and guidelines. It is a quick intubation. It doesn't matter if it goes in the trachea or if it goes in the esophagus. You can try tube 1. If it doesn't work and you're getting belly sounds, which means it's in the esophagus, try tube 2. You'll see you get airway sounds. It inflates and you have a secured airway. It's fast, it's effective, and it does work. It is not a long-term device. The second device that I want to introduce is the rapid intubation tactic for someone with a clenched jaw. This proposed device would be the needle cricothyrotomy adjunct. It's just a kit, basically. It's a tracheotomy in the field, but it's done through a needle with an inflator jet inside. Some patient who has a clenched jaw, which you can't get open to be able to intubate them, you can cric them through the neck into the esophagus, into the trachea, inflate the valve on it, and now you have airway access. It is not as good as the LMA or traditional endotracheal intubation because it is a small bore needle, but it is enough to give sustainable life until you can get them to definitive care to prevent long-term complications. Prevent them from having low dissolved oxygen within the bloodstream. Once you get to the emergency room, they can apply medications that we do not carry to unclench that jaw, or they can feasibly break the jaw if they have to. This is not a replacement for endotracheal intubation. Endotracheal intubation is a short and long-term solution for patients with a massive traumatic injury or even post-cardiac arrest where they've been saved and they need to be on a ventilator for a long time. Endotracheal intubation should be the first use, and if a difficult airway administration presents itself, the other two adjuncts should be fallback on. We do not carry these at this time. We only carry endotracheal tubes. We could go to these adjuncts, and it would help out the patient in the long run. Another focus that we do not have is that intravenous access was a problem on this call. It was a known issue because of the patient's size. It was very difficult to find a suitable vein to insert large bore IVs. Therefore, I want to introduce the next item. This is the Aero Easy IO, trademarked by Aero Properties. This is one of the brand names. However, after speaking with a few different services, this is what we use now. I'm sorry, not what we use, what they use. The Easy IO is a simple drill-like instrument that inserts a steel catheter, surgical steel catheter, into the shoulder of the patient. In this case, it would be the left shoulder, which is the quickest return to the heart. What a lot of people don't realize is that bone is filled with vascular access, great vascular access, and high circulation. By inserting the IO, you can have immediate vascular access to give the patient precious medications to the heart, quick return. It's actually quicker than going in through the left arm to the return to the heart. You're bypassing all this. Right into the shoulder, right to the heart. It saves patients' lives. It's quicker. It's easy to administer. One provider can do the IO, or the other provider is intubating. You immediately have the airway and your needle access, or in this case, needle access here, if you can't obtain needle access in the arm. It speeds things up quite a bit. Another thing is that we're having is that with all these new items, we also came across something that is, albeit a little tripping hazard in per se of protocols. Medical control, for those of you who don't know, is the central location to where ALS providers can call in and bring up their information and say to the medical control officer, this is what I have, this is what I would like to do, would you allow these? Now that is because we do a lot of what's called online orders. We have to get permission to administer certain airway adjuncts or medications, morphine, succinylcholine, etomidate. Any one of those drugs could be used, but you have to call in. 75% of our critical orders are online orders. We have to call and get permission. We are looking to reduce that amount. For the main purposes is that our medics are trained in these items since medic school. We just don't carry the items. All these processes and everything are important to what we do. So since we're already training them, most of them should be being able to allow us to have them at all times. Not saying that we can just do them whenever we want. There is a scope of practice, and as long as we're following that practice, we should be allowed to do that. And that is just something to think about with that. So by allowing us, the medical offices, to only be used for critical level requests, such as the ordering of morphine sulfate or Valium, controlled substances that we do carry, this would alleviate a lot of the second guessing from medical control officers saying, what do you have here, or why are you doing this? And paramedics that are calling in, they are well aware of that. This way here, one, not only is medical control less taxed, but also the paramedics not having to worry about he needs to get an order and wasting precious on-scene time. Some of these airway adjuncts do require, especially Neil Craig, do require a medical control office. They shouldn't have to. Airway is a basic skill. It is a skill learned by EMTs in general, which actually is in my next slide here. All the proposed changes, which are from the prior slides, should become standard. Standing orders versus online orders. Standing orders means we can do it. If they fit the criteria of what their need is for, we can do it. We should do less online orders, which is we have to call and get permission. Airway management is a basic life support skill and should be used in standing orders. EMT basics, not paramedics. Below paramedics are using the PTL and the combi tube, which are similar adjuncts as the LMA. They're using them on standing orders. Why cannot we use them? And the Aero Easy IO should also be standing order. This is two basic things. IV access, airway access. Having both of those things can greatly increase your patient's chance of survival if they're given quick enough. Less delays could exceedingly help everything. Now this is it for my draft. There is more that is coming. Thank you very much. I do have a list of references here. I do apologize because it is extremely tough to see everything here, but you will be given a copy of the slideshow. And don't worry, I will not be wearing a hoodie or a t-shirt for my final. This is just the informal. You'll see, and the room will look a little bit different too. It'll be a better angle. I had to move a computer around this weekend, so you'll be hearing from me soon. Thank you very much.